This is the renal mass side of things, so we're the bastard child of ablation now. And it used to be a big part of the meeting, now we get an hour. So let's start with the small renal mass panel. And our first speaker is Carol Watts, going to give us an update on the guidelines.
Okay, good morning. Carol Watts from Montefiore in Bronx, New York. My only disclosure is I don't actually perform surgery for renal cell carcinoma. I work in the prostate. So this is just a brief review on the AUA guidelines for small renal masses. And you're going to hear from some subsequent talks about biopsy and ablation techniques, so I'm going to just focus on the other aspects of the guidelines. So just starting with a couple of facts and figures, there's about 73,000 new cases of RCC in the U.S. Every year, and about 300,000 cases and rising worldwide every year. Higher risk in males compared to females. And by far the most common type, clear cell renal cell carcinoma, about 85% of all RCCs, with papillary renal cell carcinoma being the second most common subtype, and then a plethora of other variants following. So in terms of a patient who presents with a small renal mass, there's a few pieces to remember in terms of the guidelines for evaluation. So the basic tenet of essentially making the diagnosis is high-quality cross-sectional imaging. And this is in the form of either a CAT scan or an MRI. The presence of macroscopic fat is not 100% diagnostic of an AML, but highly, highly suggestive. And I put this nota bene in for people to remember that if the group 2 gadolinium contrast agents are safe in any stage of CKD. So if you're trying to get very good renal mass characterization, even for CKD stage 5 patients, you can use the group 2 gadolinium agents with about a 0.7% risk of NSF. Also, some chest imaging to rule out lung metastases. That's the most common location for RCC to metastasize to for initial diagnosis. And then baseline tests to obtain, CBC looking for abnormalities such as anemia or other dyscrasias, BMP, which I'll talk about in the next slide in terms of establishing their baseline renal function and GFR, urinalysis looking for hematuria or other proteinuria. ALK-Phos is also important to consider. It's unlikely to be elevated in the case of a true small renal mass, but elevated blood value may suggest liver metastasis. And from the BMP, you should assign a baseline CKD stage if it's present, if they don't already have an established diagnosis. And so I put this table in to just remind everybody of what the rough cutoffs are for CKD based on what your GFR is. And then moving on from evaluation to counseling, for small renal masses, which by the guidelines are defined as under 2 centimeters, it's important to review the natural biologic nature of these masses with your patient. They are fairly indolent. They have a less than 1% metastasis rate at less than 2 centimeters in max diameter. 20 to 25% are benign. About 15 to 20% are either high grade or locally invasive. And when thinking about how to manage the mass, you have to consider the patient comorbidities, their age, frailty, life expectancy. Referrals. I think this is probably one of the most important slides in terms of urologists thinking about being multidisciplinary and patient advocate providers. So referrals to nephrology if they have a high risk of CKD progression if you are going to intervene. So that would be patients with a baseline GFR under 45, if they have concomitant proteinuria, or if they have diabetes with CKD at baseline. And also referral to genetics counseling if they are young, so age under 46, if they have multifocal tumors or bilateral tumors, or any family history suggestive of a neoplastic syndrome or a known family history. And I put all of these up here to remind us because some of these are not easy to remember aside from the night before when you're cramming for your boards or your tests. And then in terms of counseling, the burden is on us to sort of go through the gestalt of the overall risks and benefits of the 4 categories for treatment management. So probably not thinking of radical nephrectomy for true small renal masses, but the benefit is They have a lower risk of surgical complications compared to partial, but there is a risk of de novo CKD. Partial nephrectomy preserves renal function, but has a higher risk of complications. Thermal ablation will be discussed later. And active surveillance has favorable short to intermediate term outcomes, but you do have to balance this with the concept of patient anxiety. So to surveil versus to treat for a small renal mass, these are in the guidelines. I'm not going to belabor them since I'm running out of time here, but essentially younger patients, healthier, with any high-risk features on imaging or on biopsy if performed, favor treatment. And then if you're going to pursue surveillance, this is the general rubric from our guideline, but essentially this is entirely imaging-based. You can see it. It's not so nefarious as, say, MRI for prostate. So periodic imaging, either 3 to 6 months, with some form of cross-sectional or ultrasound imaging, depending on how visible the tumor is. And then, these are the categories to consider moving on to treatment in the bottom left box. And then surgical principles, so partial nephrectomy is favored for T1A tumors if they are Bosniak 3 or 4 cystic lesions, if they have an anatomic or functionally solitary kidney or bilateral tumors, any familial RCC syndrome, pre-existing CKD or proteinuria, of course, young patients, or those who have moderate or severe hypertension or these other comorbidities. Very basic partial nephrectomy surgical principles. You want to prioritize negative margins. Minimally invasive approach is always preferred. If there are suspicious lymph nodes on imaging or intra-op, you should perform a regional lymph node dissection and consider enucleation as opposed to taking a rind around the tumor if they have any of these conditions present. And then I put this last 2 slides in here is for follow-up. Don't lose your patient. So follow-up is entirely based on imaging, and it's going to be based on the initial tumor disease risk stratification. So basically, any small renal mass is going to fall into the low or intermediate risk category based on size. And I put this in to remind you that if you have a positive surgical margin, it's recommended that you assign them to the next higher risk category. And then this is just the reminder for everybody that imaging is the way we follow up because this is entirely imaging based. And so these are the month intervals on the top and then their risk category on the left for when to obtain cross-sectional or ultrasound imaging and periodic interval chest x-rays to look for METs. And anything beyond 5 years is essentially up to the discretion of the urologist. Thank you.
Thank you. For sake of time, we're just going to continue.
So next up, we have role of renal biopsy. Who, when, why should it be staged, and should ablation be performed at the same time? We have Dr. Guy. Thank you for joining us.
Thank you. It's a pleasure to be here this morning, and I'm going to be speaking on role of renal biopsy, and also discuss perhaps, should the renal biopsy be staged, or should an ablation and a biopsy be performed in a single setting. Right. So the first question that comes up really is, should a solid enhancing renal mass on imaging always be considered as an RCC? And the answer really is no. One of the first studies which looked at close to 3,000 renal masses over a 30-year period, who went to surgery, showed that about 30% of these tumors under 4 centimeter turned out to be benign. And they did observe that as tumor size increased, there was a significant increase in the odds of having a malignant tumor. There were a few other studies at about the same time, again showing very similar results, that 30% of masses, small renal masses, do turn out to be benign on final surgical histology. Most commonly, they turn out to be oncocytomas and fat-poor angiomyolipomas. We know that imaging has its limitations when trying to kind of differentiate benign from malignant masses within the kidney. Here's an example of a mass which did not show any fat on the underhand CT. It is actually hyperdense to the renal cortex. In the corticomedullary phase, it shows enhancement. There's some washout on the nephrographic phase, and we thought that this is going to be an RCC, but of course, the biopsy did come back as an angiomyolipoma in this case. And here's another example of a mass which is about 4 to 5 centimeters in its maximum transverse dimension. Looks like an RCC on imaging. The patient went on to have a biopsy, and this time around, this came back as an oncocytoma. So we know that imaging has its limitations. On follow-up ultrasound, this mass had actually grown over a period of a couple of years, as you can see here. We are aware that there could be biopsy sampling error, and there's secondary to tumor heterogeneity. This patient came back, underwent a second biopsy at this stage, and it again showed it to be an oncocytoma. Risk of tumor seeding from renal biopsy, we know that it is very, very less. There have been very few kind of anecdotal reports of seeding. In contrast to some other tumors like pancreatic cancer, even HCC or GI stromal tumors, which do have a higher risk of seeding from a needle tract. Looking at safety and efficacy of renal biopsy, this was a study from our center led by Tony Flelly and Mike Jewett at that time. We looked at about 500 renal biopsies over a period of 10 to 12 years. The initial biopsy was diagnostic in about 90%, and again, very similar to previous results, about 20% of them were benign, with a ratio of 2:1 for oncocytoma to AML. Amongst the patients who had a non-diagnostic initial biopsy, the ones who did go on to have a second biopsy, the repeat biopsy was diagnostic in about 83%, so overall it yielded a diagnosis in about 93 to 95%. And there was a strong concordance between the biopsy and the surgical histology, again, amongst those patients who went on to surgery after the initial biopsy. There were some adverse events in this cohort that we had looked on, and almost all of them were just small perirenal hematomas, a little bit of blood coming out from the coaxial sheath, except for one grade 3B AE, which was actually an active bleed following the biopsy and required angioembolization. So based on these publications over the last few years, all the major guidelines now do recommend a biopsy before treatment planning for small renal masses. But they don't necessarily mention if the biopsy should be performed in a staged manner versus if they can be performed at the same setting concomitantly at the time of the treatment itself, or thermal ablation in most cases, except for the American Society of Clinical Oncology guidelines, which I think they kind of clearly mention that it should be performed in a staged manner. So you need to have a biopsy beforehand so that it can help you in treatment planning and decision. I will, however, highlight a recent study here which looked at sequencing of renal mass biopsy and ablation, looking at staged biopsies versus concomitant biopsy and ablation at the same setting. The authors here queried the National Cancer Database, looking at trends and existing practices over a period of 10 years. They found about 6,300 patients that they were able to include in this analysis, about half of them who had a staged biopsy, and a little more than half, about 3,400 of those who had a concomitant biopsy and an ablation at the same sitting. And they observed that concomitant biopsy and ablation was more frequent until 2012, and in the last couple of years of their analysis, they found that the staged biopsy was more commonly seen, as you can see in the graph out there. They also observed that private insurers, so health costs, did relate to a higher likelihood of a concomitant biopsy and ablation at the same setting. At the same time, they also observed that there was greater odds of inpatient hospital stay and complications associated from the procedure if the patients underwent a concomitant biopsy and ablation at the same setting. So really, to summarize, biopsy is recommended prior to treatment decision by all major guidelines. We know that up to 30% of masses may turn out to be benign on final histology. Stage biopsy is therefore advisable and preferred for biopsy for treatment planning. Perhaps is also associated with lower odds of complications, but this has to be weighed against additional healthcare costs. Thank you.
Our next speaker is Dr. Jarrett, who's going to be presenting type of ablative technology for small renal masses.
Good morning, everyone. started here. The options for ablation are the most common: radiofrequency ablation, cryoablation, microwave ablation, and irreversible electroporation are the four most common. Just to go through briefly, RFA, going to do the advantages and disadvantages. We don't have much time to do it, so we're going to run through quickly. RFA is really the initial renal ablation techniques: radiofrequency power using alternating electrical current, thermal coagulation necrosis over 60 degrees centigrade. Advantage of this is it's extensive outcomes data. I was talking to Jeff. They presented their data with all over 10 years, single probe, and relatively short treatment time. So those are the advantage of RFA. The disadvantage is that you cannot see the kill zone with RFA. And it may be less effective with large tumors due to charring. You get a lot of charring with RF, or central tumors with the heat sink effect from blood vessels. So those are the downsides of RFA, but it's certainly the tried and true method in most of the studies. Cryo is another thermal ablation using cold temperatures, argon-based gas, low temperatures below 40 degrees minus goes to cell death. And you can see here's a typical complicated cases here. You can see the probes placed, the ice ball, and even around complicated structures, you can sneak these probes in and know where your kill zone is so you feel more comfortable when you're treating in tight areas. The advantages of cryo are there's extensive data as with RF. I think the big advantage is the visualization of the ice ball with the kill zone within 5 millimeters of the edge. It's been shown in studies it's safe near the collecting system, and you can get larger tumors over 4 centimeters, which is hard to do with RF. The disadvantages are the long treatment times, the multiple probes, which is not easy. Once you get one probe in there, you get a lot of artifacts. So once you start getting into multiple probes, it's pretty hard to see. And the higher risk of bleeding, it's more with laparoscopic, but even with percutaneous, you have a higher risk of bleeding with the cryo. Microwave. I think microwave in a lot of centers is replacing RFA. Use of electromagnetic waves over 60 degrees, thermal coagulation necrosis. You can see here's a small tumor here. The nice thing is it's a single probe, so you don't get all the artifacts. It's a single thin probe. The big advantages are single probe and more efficient heating compared to RFA. You don't get the charring. And by not getting the charring, you can have quicker treatment times with less heat sink, allows you for faster treatment, and also gives you the ability to treat larger and endophytic tumors. The disadvantage is the less predictable ablation zone. There is the potential for more severe injuries. Unlike cryo, you cannot see your kill zone. And so when you're close to collecting system, bowel, visceral organs may not be optimal. And it requires general anesthesia. Generally, the cryo can be done under a local. RFA usually can. Microwave, really, it's hard to do under a local anesthesia. Irreversible electroporation is one of the newer ones that's coming out. It's a non-thermal ablation technique. Multiple probes placed to create an electric field between them, leading to apoptic-like cell death, preserves non-cellular tissue within the kill zone. So what you're doing is you're getting kill without killing connecting structures, collagen, fat, other non-cellular areas. And you can see here, there's a lesion here in the pancreas. You can see you've pervaded these 3 probes, and you've created a kill zone within it. The advantage is it's a lower risk for collateral damage, no thermal injury. Once probes are placed, it's quick treatment times, but it does take a long time to get the probes placed accurately. The disadvantage, really, it's new technology, multiple probes needed to create the field. So once you get multiple probes, it's harder to get them positioned properly. Interpretation of ablation zone on follow-up imaging, there's not non-enhancing tissue, so how do you approach that? And it does need not just general anesthesia, but it needs EKG pulsed synchronization like with ESWL to do, and of course the cost. So here is a summary slide of all of the areas here. The efficacy, they're all highly efficacious and early studies. The best data is for cryo and for RFA, but microwave is evolving. They all appear to be safe. Cryoablation is probably the safest due to the ability to see the ice ball. The ability to treat large central tumors, really there's a limitation with the RFA, but with cryo and microwave you can accomplish that. We're waiting to see with IRE. Ease learning curve, once again, cryo is hard due to multiple probes. RFA is a single probe. Microwave is a single probe with big kill zones, so that's probably the easiest. Ablation time, obviously, microwave is probably the best. Cryo is the worst. And the cost, you can see here, RFA is probably the most cost-effective, followed by the microwave with the cryo and electroporation being the lowest. Just to mention, the only ones that have CMS codes are cryo and RFA. So when you're doing this, if you want to get reimbursed, those are the only ones with codes. So in summary, RFA, cryoablation, microwave, all established from cancer and safety point of view. RFA and cryo have very good long-term data that's reliable. I think there's emerging data, the microwave that looks promising and probably comparable or better than RFA. IRA is still investigational, but I think we're getting data from pancreas and prostate to try to support that. Cancer outcomes for this approach are approaching those for partial nephrectomy in well-selected patients and if you give the option for retreatment. So for a single treatment, it's not going to be as good, but if you give retreatment, you'll see equivalent outcomes in many situations. Cryo has the advantage of ice ball visualization. Microwave has the advantage with ease and large tumors, and the role of IRE is emerging. Thank you very much.
Thank you very much. Our next speaker is Dr. Molina, who's presenting ablation in oligometastatic disease, a medical oncologist perspective.
Thank you for having me here today. I'm going to be speaking about ablation in the setting of metastatic disease from the medical oncologist perspective. These are my disclosures. So I'm going to try to go over treatment of metastatic kidney cancer very briefly, review some of the guidelines for the use of ablation in metastatic disease. I actually didn't find much, and give you some examples of clinical cases. So in terms of treatment of metastatic kidney cancer, the past 20 years, we've had significant progress in advanced RCC, going from cytokines to targeted therapies to immunotherapy. So this is where the bulk of my practice lies, treating patients with metastatic disease. Despite these advances, looking at the IMDC database consortium criteria, the 2-year overall survival probability for our patients with poor risk disease, for example, is 8.8 months. Intermediate, a little bit over 2 years, and the favorable have better overall survivals. So when I think of my patients and treating them with systemic therapy, the goals of therapy are palliative, so I'm trying to decrease the burden of disease, trying to palliate their symptoms, and trying to prolong survival. So what are the guidelines for the use of ablation in metastatic disease? So looking at the NCCN guidelines, we know that there is a role for ablative techniques in stage 1, T1A, and also T1B disease. Looking at relapsed or stage 4 disease, there is a little section here that talks about metastasectomy or stereotactic body radiation therapy or ablative techniques for oligometastatic disease, both for clear cell histology and also for non-clear cell histology. I did a PubMed search, looked for data, and what I found for the most part, as Dr. McClure mentioned earlier, is very limited data, some retrospective studies. The European Association of Urology guidelines, this is an updated guideline from 2022, discusses to offer active surveillance or thermal ablation to frail and or comorbid patients with small renal masses, as we've heard. This is described to be a weak recommendation, and also do not routinely offer TA for tumors greater than 3 centimeters or cryoablation for tumors greater than 4 centimeters, also a weak recommendation in this update. So as a medical oncologist, I look at this and for sure I'm not talking to patients about the potential of ablation when their tumors are greater than 3 centimeters or even greater than 4 centimeters. Occasionally, I will present these patients to Dr. McClure up here in the podium, and rarely do we treat patients with larger tumors. The benefits that I found based on retrospective data available in the setting for metastatic disease include minimally invasive, so as compared to surgery, for example, there appear to be a favorable safety profile, potentially less morbid, offers effective local tumor control, may have durable disease-free survival after treatment, specifically in oligometastatic disease, and for my patients, it may delay the start of systemic therapy. So let me show you just 2 examples here, and I have the oligo in parentheses because the majority or the bulk of my patients do not have oligometastatic disease. The bulk of my patients have extensive disease or low volume disease that we're trying to decide what to do. So case 1 is a 63-year-old gentleman. He has multiple comorbidities, diabetes, coronary artery disease. He underwent a radical nephrectomy in 2015 for clear cell RCC. 7 years later, he developed biopsy-proven recurrence in the lungs. He had about 3 lung nodules. These were small. And he falls within the favorable risk group per IMDCC. He was definitely not interested in surgery. VATS procedures were offered to him. And he also wanted to avoid any toxicity from systemic therapy, either from the TKIs or the immunotherapy. This is just sequential scans pre and post cryoablation of a lingular nodule. We were concerned about the location of this nodule and the proximity to the heart. One of our interventional radiologists was able to successfully ablate this nodule, and currently he does have other sub-centimeter lung nodules that have remained stable, and he will be reassessed actually next month for potential additional ablation. And we ablated this nodule because it was the only one over the course of many months that grew slightly. Case number 2 is a very young guy, 49-year-old fit male. He has an atrophic right kidney from birth, CKD stage 4, and was found to have a left renal mass. He underwent a left partial nephrectomy for T3A clear cell RCC. And unfortunately, on 6-month surveillance scans, he was noted to have bilateral lung nodules, mostly sub-centimeter. And he had a new 1.5 centimeter right adrenal nodule. Both the lungs and the adrenal were biopsied and confirmed metastatic RCC. So the issue I had was, given his comorbidities of CKD, he has pretty profound nephrotic syndrome. I was concerned about giving him a TKI, such as pazopanib or Votrient or pazopanib or any of the other agents. So I offered him first-line therapy with ipilimumab plus nivolumab, which can affect kidney function. Fortunately, he was able to tolerate this regimen. We also presented him at our tumor board and discussed focal therapy. So this is a pre and 1 month post pulse electric field ablation of a 1.3 centimeter right lower nodule. He also underwent cryoablation of the right adrenal mass here. And following completion of induction IPI and NIVO, his scans are stable. He's pretty upset about this. He wants everything to be gone, so we're actually presenting him again to discuss further ablation of some of the lung nodules. So from my perspective, ablation of metastatic RCC lesions is safe. It's less comorbid. It may delay the start of systemic therapy, particularly in patients with favorable risk disease. It can preserve quality of life, has the potential to maximize therapeutic benefits. The retrospective data that I reviewed is compelling, but there are no randomized clinical trials that demonstrate survival benefit. I think it is important to use a multidisciplinary approach. I very quickly went over these cases, but we spent hours and hours presenting to Dr. McClure here on the podium about which patients we should ablate. Thank you.
So we do have, I do want to take a minute or two if anybody has any questions. I know we're behind schedule, but any questions for the speakers? Please.
Anna, that was a nice talk. Thank you. Is there any evidence that any of these metastatic focus of patients that are on systemic therapy like beget new metastasis on their own, or because that would be a really good argument for, treating those oligomets. It seems to me that, it may delay systemic therapy, but that may be just predicated on, our looking at the scans and being nervous about growing nodules. And that's, that's we're sort of, we're delaying that, that eventuality because you're treating the largest nodules that you could see at any given time. But, it would be really beneficial if if we knew that those, spots were actually going to shower off more metastasis themselves.
So I'm not familiar with any data that describes that. When we are ablating these lesions, so the patients that we are trying to delay systemic therapy are primarily patients with favorable risk disease. So these are the patients that have long overall survivals. We can monitor these lung nodules for years and years without having to start systemic therapy. At the onset of any change, we do go ahead and start systemic therapy. The other thing is we will ablate or radiate or resect patients in situations where they are on systemic therapy, they've had significant reductions in tumors elsewhere, and maybe one lesion is growing, as Dr. McClure mentioned before. In those patients, I'm not going to switch to systemic therapy. I'm going to try to treat that one lesion and try to keep them on therapy.
It would be interesting to know if those ones were, had evidence of being sort of resistant to systemic therapy molecularly. So I mean, if we could somehow assess that.
We do collect the specimens, at the time of biopsy and doing genomic studies, but I don't have the data.
I have a question for Dr. Guy. On the guidelines should recommend, if not prescribe, that we should do a biopsy stage to ablation, but they're not as prescribing for partial nephrectomy. What is your personal thought on biopsy then? I find that troublesome that we can do surgery but not an ablation without a biopsy.
So, I can tell you in our practice in Toronto, every renal mass does have a biopsy. The decision whether they're going to go for a partial nephrectomy or an ablation will be taken afterwards. So given the fact that, 25, 30%, whatever the number is, may not require any treatment, plays a role in deciding if the patient is going to have a biopsy or not. For us in Ontario, in Canada, we follow the CCO guidelines, the Cancer Care Ontario guidelines, and that actually specifically mentions any form of reimbursement for thermal ablation for sure, you need to have a biopsy beforehand. So in our practice, I would say that every small renal mass under 4 centimeter will have a biopsy and will be staged in our practice always.
Quick question. I mean, I worked at Hopkins for 10 years. I'm back there and send all our pathology there. I can count the number of times on one hand that a biopsy came back definitive oncocytoma from a needle biopsy. So I'm just understanding how that fits into your algorithm.
Yeah, and our pathologists, we have these discussions in our MDTs always. They always say that cannot rule out, right? I mean, that kind of disclaimer stays there. And that's why if they do feel that this is most likely an oncocytoma, and we do have experienced pathologists, we follow them up always. They have an ultrasound almost every 6 months. If at any stage the mass changes or grows, we would re-biopsy them. That's the general practice. I don't think we have enough evidence, even for definitive oncocytomas, like what's the history of these masses. So we do follow them closely.
I also think that if you have an oncocytic neoplasm at biopsy for a tumor that's less than 5 centimeters, the pathology of that acting in an aggressive manner is extremely low. So if it comes back oncocytic neoplasm and you have a 2-3 centimeter mass, who cares? Like, you can watch it safely. I'm not worried that a 3 centimeter chromophobe is going to met out.
And generally in our practice, they're followed up by ultrasound. We would do a cross-sectional imaging only if there's a change in the mass.